Good afternoon to one and all. As we all know, every month Transition Medicine Academic Society is giving you the academic fees without any fail till now. And today our plan is to conduct a clinical club, and that too is from our postgraduate students. So here we are eagerly waiting for the interesting cases from your side also. So hence for chairing this section, I'm inviting Dr. Abhishek B. Gowda, our president of PIMAS, for chairing this section.
Yeah, good afternoon, everybody.
Good afternoon, sir. Sir is an additional professor in the Department of Transition Medicine from JIPMER, Puducherry. After completing MD and MD in Immunohematology and Blood Transfusion, sir has bagged the award of Master of National Academy of Medical Sciences and Postgraduate Diploma in Clinical Research too. Sir has bagged ISTM Young Scientist Award in the year 2019, Award of Medical Scientist Exchange Program of NAMS, Harold Gunson Fellowship Award in the year 2021, H.T. Shuri Award in the year 2021, and has got 82 publications and is a co-author of Handbook of Autoimmune Hemolytic Anemia. We welcome you, sir.
Okay, thank you. So I hereby welcome all the participants for this clinical club, which is going to be a very scientific session. And today we have two cases, and also it happens to be World Hemophilia Day today. So aptly one of the cases is chosen. And so the first talk will be by
warm good afternoon to one and all. I am Dr. Akshaya, Junior Resident in the Department of Transfusion Medicine, Jubilee Mission Medical College. I would like to thank Transfusion Medicine Academic Society for giving me an opportunity to present my case report titled Hemophilia with Thrombosis. It is an honor to have Dr. Abhishek B. to chair this session. Without much delay, let's move on to the case. A 39-year-old male, known case of severe hemophilia, presented to the emergency department with history of deviation of angle of mouth, slurring of speech, weakness of left upper limb and lower limb lasting for 5 to 10 minutes. After which he had a similar episode 2 hours later, and the symptoms got resolved by itself, for which he presented at the emergency department. He gives a past history of intracranial bleed at 9 years of age, of which the reports are unavailable. He was not on any prophylaxis. He has had frequent episodes of hematorosis and was taking on-demand therapy only. A left knee swelling was noted 3 days back, for which he took 750 international unit of anti-hemophilic factor for 3 days. He gives a family history of hemophilia A in maternal uncle. On clinical examination, the patient was conscious, oriented, febrile, and heart rate was 108 beats per minute, regular. BP was 150/90 mmHg and bilateral pearl. On CNS examination, there was no deviation of angle of mouth, no dysdiadokinesis or nystagmus. Finger to nose test was negative. Power was 5/5 on all limbs. Deep tendon reflexes and plantar reflex was normal response bilaterally. Other systems were within normal limit. So routine lab investigations and inhibitor screen was sent. A sample for rotum was also sent. Suspecting intracranial bleed, he was administered 1500 international unit, which is 60% of factor VIII correction based on his body weight. Then he was shifted for MRI brain screening. This was the lab investigation results. Hemoglobin was 16.3, total count of 8,530, and platelet count of 2.4 lakhs. Inhibitor screen was negative. Random blood sugar was 149. Total cholesterol was 214. HDL was 32. LDL cholesterol was 150. LFT and RFT were within normal limits. These images show the MRI brain screen. There was an acute infarct in the right lentiform nucleus extending into corona radiata. There was also a microbleed noted in the left gangliocapsular region. This was the ROTEM findings. The ROTEM findings of this particular patient is given on the right-hand side. It is expected that findings of hemophilia is clotting time, or the CT, clot formation time, that is CFT, is expected to be prolonged. Maximum clot firmness and alpha angle is expected to be decreased. So the expected hemophilia graph is given on the left-hand side. In this, the positive findings which I took from my case is severe hemophilia A without inhibitor, CVA, an acute infarct with a microbleed, and hypercholesterolemia. A cardiac evaluation was underwent. ECG was normal, sinus rhythm, no arrhythmias. Echo finding was concentric LVH, IVC normal, fair systolic function, and no other abnormalities. As management, the patient was shifted to the neuro ICU and thrombolysis was deferred. He was started on antiplatelets and statins under prophylactic factor correction of 30%, which is 1,000 international unit on alternate days. Physiotherapy was initiated and patient was symptomatically better and discharged on day 3. The following was the discharge advice that was given. TAP ecospirin 75 mg OD, which is low dose aspirin antiplatelet, was given. TAP Biotor 40 mg HS, which is a statin. Factor correction of 30%, that is 1,000 international unit on alternate day, was given. Moving on to the discussion of this case. Hemophilia is a rare X-linked genetic disorder which is due to factor VIII deficiency. Hemophilia A is much more common than hemophilia B, which accounts for about 80 to 85%. Many goes undiagnosed as per WFH annual survey. The pedigree shows X-linked recessive inheritance. The severity of hemophilia is divided into 3: severe, moderate, and mild. This severity is based on the factor level. If the factor level is less than 1%, it is severe, where there is severe spontaneous bleeding. 1 to 5% comes under the moderate group, where there will be fewer bleeds, which is usually due to a traumatic cause or presents as a hematorosis. Mild cases where they have a factor level of 5 to 30% will be having even fewer bleeds, which is mostly due to a post-surgery or post-traumatic. Clinical presentation of hemophilia. Hemophilia clinical hallmarks are prolonged, spontaneous, and or traumatic hemorrhages. Mostly it is seen in the musculoskeletal system, where it presents as an intra-articular bleeding. Most commonly affected joints are ankle, knees, and elbow, and less likely the shoulder, wrist, and hip. Also, it bleeds into the muscles and mucosal soft tissue. Less commonly, other soft tissues, brain, internal organs are affected. If it bleeds into the joint or a muscle, it presents as a tingling or a bubbling sensation. Stiffness will be there, pain and warmth will be seen, and unusual limb position is also seen. Intracranial bleed will present as nausea, vomiting, headache, drowsiness, and confusion. We can also find visual changes and loss of consciousness in patients. Neck or throat swelling, neck or throat bleeding presents as pain, swelling, difficulty in breathing or swallowing. Abdominal or GI bleeds presents as pain, tenderness, swelling, and bleeding stools. Iliopsoas muscle is the most important muscle where the most common bleeds are occur. It presents as back pain, abdominal pain, tingling or numbness in the thigh, decreased hip range of motion. Without adequate treatment, internal bleeds can lead to serious complications and life-threatening situations. If a the universal dictum that we follow is, if a patient complains of any of the symptoms, believe him and treat. Moving on to what is stroke. Brain injury with neurological dysfunction due to ischemia, hemorrhage, or cerebral venous or sinus thrombosis. The major risk factors of stroke include hypertension, diabetes, high LDL cholesterol levels, smoking, heart and blood vessel diseases like CAD, atrial fibrillation, or valvular diseases. Other factors that contribute to stroke are age, where the stroke risk increases with age; gender, where men are more commonly affected; family and family history and genetics. If a patient's parent, any of the parents have had a stroke, he is prone to develop a young stroke at a young stroke. Other conditions like brain aneurysm, AV malformations, viral infections, and inflammatory conditions like lupus or rheumatoid arthritis also contribute to the same. WFH, in their guidelines for management of hemophilia in their third edition, mentioned that improved life expectancy has led to a greater age-related diseases. Cardiovascular diseases, hypertension, and other cardiovascular risk factors have increasingly been reported in adults with hemophilia. People with hemophilia are equally or even more prone to obesity, hypertension, and diabetes than general population, and that causes disease despite the clotting defect. Most evidences suggest that severe form is partially protected against myocardial infarction, stroke, and venous thromboembolism. This is a study where there was a comparison between the ischemic stroke in congenital bleeders and high cholesterol screen share. Sorry for the inconvenience. Let me repeat the previous slide. Ischemic, there was a study based which resulted in a comparison of ischemic stroke in congenital bleeders and myocardial infarction and other acute coronary syndromes. It is seen that the major risk factors that contributed to this was hypertension, diabetes, high cholesterol, obesity, and heart diseases, followed by replacement therapy. This was followed by old age, surgery, and smoking. CV and hemophiliacs. Hemophilia patients are prone for hemorrhagic stroke. Spontaneous thrombotic events in patients with hemophilia are very rare, and it can lead to diagnostic and therapeutic difficulties. The exact mechanism of spontaneous thrombosis is not well understood. Cases have been reported for following intensive factor replacement therapy. It is hypothesized that let me repeat. CV in hemophiliacs. Hemophiliac patients are prone for hemorrhagic stroke. Spontaneous thrombotic events in patients with hemophilia are very rare, and it can lead to diagnostic and therapeutic difficulties. The exact mechanism of spontaneous thrombosis is not well understood. Cases have been reported following intensive factor replacement therapy. It is hypothesized that the treatment with factor replacement therapy transforms these patients into almost healthy individuals, putting them at the same risk as healthy individuals. In certain studies, it was mentioned that dysregulation of miRNAs that target the mRNAs disturb the gene expression. Thus, there is an alteration in the protein levels involved in coagulation cascade. That leads to bleeding disorders or thrombosis. Management of CVA in hemophiliacs. WFH recommends clinical management based on basin factor 8 or factor 9 levels. The antithrombotic therapy in patients with inherited bleeding disorders are done after evaluating the following 4 principles. That is, bleeding phenotype of the patient, characteristics of the anticoagulant, intensity of anticoagulant therapy, and duration of planned therapy. Bleeding phenotype. The consideration here is how frequently and how severely the patient bleeds. Whether bleeding is spontaneous or occurs only when provoked. Hemophilia patients can be divided into 2 types, with inhibitor and without inhibitor. The persons without inhibitor have a predictable response to clotting factor replacement, and bleeding can be reliably prevented or treated. Those with inhibitors have much less predictable hemostatic response to the bypassing agents. The risk of uncontrolled bleeding is thus therefore almost always outweighs the benefit to anticoagulation in patients with inhibitors. Characteristics of anticoagulant. Anticoagulant selected is based on whether it is more easily reversed and have shorter half-life, just like the unfractionated heparin or the low molecular weight heparin. These are preferred. If we go for an oral therapy, we choose vitamin K antagonist or dabigatran as they have available antidotes. The main factor here we have to remember is whatever anticoagulants we give, it should be under the factor protection where the trough level of factor 8 or factor 9 activities are maintained more than 30%. The decisions for individual patients can be made on a case-by-case basis. Characteristics of antiplatelet agents that we use. Single agent antiplatelet therapy is avoided in severe hemophiliacs as the risk of spontaneous bleeding is potentially quite high in the absence of ongoing prophylactic therapy. Low-dose aspirin is well tolerated by patients with mild hemophilia, but for patients with moderate hemophilia or those on the continuous prophylaxis must be made on the individual basis. It is not advisable to typically use dual antiplatelet therapy without prophylactic replacement, factor replacement, so that the trough level, factor level remains more than 30%. This is a study that was given in the Journal of American Society of Hematology. In this itself, we can see that the green color shows how readily we can use it for hemophiliacs. It is seen that from this more than anticoagulant or dual antiplatelet, single antiplatelet is better tolerated in mild and moderate hemophiliacs. And in severe hemophiliacs, in condition, it is avoided. It is expected to avoid the use in severe hemophiliacs. The intensity, the third consideration was the intensity of anticoagulation therapy, coagulant therapy. It is divided into three. That is high intensity, standard intensity, and low intensity. High intensity means like the loading bolus doses that we give during the initiation of venous thromboembolism therapy. Then standard intensity, these are the doses that are used in the treatment of VTE. Low intensity are like the prophylactic doses of anticoagulation we give for VTE. The bleeding risk is associated with each level of intensity. That means the risk is increased in high intensity regimens as compared to the low intensity regimens. So the approach is to use high intensity anticoagulants for a minimum duration and under replacement clotting factor protection. In case of significant, those patients with significant history of bleeding or frequent bleeding, we can consider lowering the intensity of anticoagulation in these patients. Moving on to the fourth consideration, that is the duration of antithrombotic therapy. Duration can vary from very short, that is like what we use for any intervention, to prolonged or even indefinite duration of chronic conditions like prolonged antiplatelet therapy used for CAD. For people with inherited bleeding disorders who require factor protection, it is better to treat them for a shortest reasonable duration. Even though the standard recommendation of 12 weeks is recommended, we can use it for use the treatment for 6 to 8 weeks. It is another similar study on treatment of cardiovascular diseases in people with hemophilia A and B, where atrial fibrillation in hemophilia was treated under this algorithm. Antithrombotic therapy was based on basal factor 8 or 9 levels and stroke risk. The stroke risk is evaluated by the CHAD score, which is the abbreviation of congestive heart failure, hypertension, age, diabetes mellitus, and stroke risk. The algorithm goes as follows. Basal factor level of equal to or more than 30%, we consider the CHAD score. If the score is less than 2, we go for low dose aspirin. If it is more than or equal to 2, we go for vitamin K antagonist. For basal levels, that is 5 to 30%, we go for low dose aspirin. If the basal levels are between 1 to 5, we again consider the CHAD score, where if it is the risk is less than 2, there is no need for any antithrombotic therapy. If it is more than or equal to 2, we go for low dose aspirin. For basal level less than 1%, equal to a severe hemophilia, we consider if they are on CFC prophylaxis. If they are on prophylaxis, again CHAD score is considered, and if it is less than 2, there is no need for antithrombotic therapy. If it is more than or equal to 2, we go for low dose aspirin. If they are not on any prophylaxis, then no antithrombotic therapy is accepted. So I would like to conclude by saying that hemophilia is a hereditary hemorrhagic disorder characterized by factor 8 deficiency. Severe factor 8 deficiency can cause bleeding within the joint, soft tissue, and muscles. Comorbidities like hypertension, hyperlipidemia, and diabetes mellitus have significantly increased the rates of CVA and are more common in hemophiliac patients. Thrombotic events in hemophilia are rare and possibly underdiagnosed. So CVA here forms a paradox to the underlying disease. The mechanism of thrombosis in these patients needs to be further studied and optimal management should be defined. There are no strict guidelines on the management are available. A case-based approach in considering the bleeding risk must be made. Preventive strategies are needed to be identified in such patients with comorbidities. These are my references. Thank you.
The case is open for discussion now. Anybody has questions? Can raise your hand or unmute yourself and Anybody? Okay. Let me start with something. Dr. Akshaya,
Hello.
did you see any notice with or relation? I did not see any history of COVID vaccination in the patient.
He has taken both COVID vaccines. He has not taken his booster doses. That is what the history is.
When was the last dose?
He took it in early 2021.
And this episode was noticed in?
This was noticed very recently, sir, in the month of March. On March 9th, he presented to the emergency department on March 9, 2023.
And the reason why I asked is few episodes of thrombosis and all that has been linked with COVID vaccines. So I thought.
Okay, sir.
So anybody needs to ask any question?
You can unmute and ask.
How would the management go if the patient was diagnosed with inhibitors?
Dr. Akshay, did you hear that?
Yes, sir.
Madam is asking how would the management differ if the patient had inhibitors?
So we would have considered Novo 7, sir.
This is factor 9 deficiency, right?
Factor 8 deficiency.
Factor 8 deficiency.
Is there any risk factor for inhibitor development by patient related or treatment related?
Yes. Because during the therapy, we are giving a correction factors, no? So it can lead to an inhibitor development also.
What could be the patient related risk factors, if any? Like,
I didn't get you.
could you tell some patient related risk factors for inhibitor development, if any?
Usually when using recombinant factors and in certain mutations, we can see the inhibitor development on the from the side of patient. And if every 6 months, we screen the patient for inhibitor screen.
Okay.
Good afternoon all. I'm Dr. Hadia Tahir, doing my residency in transfusion medicine at Government Medical College, Thiruvananthapuram. And today's topic for presentation is resolving cross-match incompatibilities and overcoming transfusion challenges, a case-based approach. As we all are aware, Government Medical College, Thiruvananthapuram is a high-volume tertiary care center with around 200 blood component issues per day, And we come across cross-match incompatibilities on a daily basis, and that too in odd times. And each case is unique and its management varies from one another. So here I have highlighted 6 cases which we encounter as cross-match incompatibilities, the challenges we faced and how we manage each one. So without further delay, let's move on to case number 1. So case 1 is that of a 44-year-old male who was admitted with short febrile illness, and there was no history of transfusion or any sensitization event. There was no bleeding manifestation and the patient was hemodynamically stable, and on examination, there was pallor and hepatosplenomegaly. And the hematological parameters revealed a hemoglobin of 5.8 gram percentage and a platelet count of 73,000. There was laboratory evidence of hemolysis with increased serum LDH levels and indirect hyperbilirubinemia, and the peripheral smear showed the evidence of hemolysis. An immunohematological workup was done for the patient, and the blood group was BRHD negative with no blood group discrepancies, and that was positive. Autocontrol was positive at 37 degrees, and antibody screening and identification was pan-reactive, which was of the same grade. So the challenge we faced was that here we had a cross-match incompatibility with a positive DAT and a pan-reactivity in the identification panel. So this is a case of a male with no sensitizing events with positive reaction at autocontrol at 37 degrees Celsius and a pan-reactivity with same strength in the identification panel cell, and the patient showed clinical features of hemolytic anemia. And we didn't proceed further workup as it was a case of autoimmune hemolytic anemia with no prior sensitization, and all these features strongly suggestive of autoantibody. And the patient was admitted and started on steroid injection, and the hemoglobin was not improving. And on day 2 after admission, the hemoglobin fell to 4 gram percentage, indicating a transfusion. And we issued the best cross-match compatible unit as 100 ml aliquot, and the transfusion was done under strict monitoring. The intra-transfusion and post-transfusion period was uneventful, and a total of 3 aliquots was given, and the patient started responding to steroids, and the hemoglobin rose to 7.6 gram percentage. So this was a case of autoimmune hemolytic anemia, which was incidentally diagnosed in a male with no prior sensitization events, who was managed with the best AG cross-match compatible unit. And the transfusion of patients with autoimmune hemolytic anemia is actually a clinical decision that should be based on the balance between the risk and the clinical need. And it should not be withheld solely because of the serological incompatibility. Now moving on to the case number 2. So this case was of a 33-year-old female who presented to the hematology OPD with complaints of fatigue, dyspnea on exertion, and syncope. The patient presented 14th day post LSCS. She was para 2 living 2, and on examination, the patient was pale, icteric, and hepatosplenomegaly was present. And on the hemogram revealed hemoglobin of 2.4 gram percentage, and other cellular counts were within normal limits. And there was laboratory evidence of hemolysis with indirect hyperbilirubinemia and an elevated LDH levels, and the peripheral smear showed the presence of spherocytes. And there was a transfusion history. 1 unit of PRC was transfused in the 2nd trimester, and there was a history of recent transfusion post LSCS on day 1, and that is 14 days prior to the presentation, and the hemoglobin then was 8 gram percentage, and now the patient presented with a hemoglobin of 2.4 gram percentage. So we did the immunohematological workup, and the blood group was ARHD positive, and the DAT was positive. Antibody screening was pan-reactive with varying grades in the ortho 3-cell panel, and there was a pattern observed in the biorad 3-cell panel. And the antibody identification was reactive in all except one panel. So this is the antigram showing the 3-cell and the 11-cell panel of biorad. And as we can see, there was a reaction except in 1 in 3-cell, and there was a reaction except in 2 in the 11-cell panel. So the challenge we faced was there is a pan-reactivity in the ortho 3-cell panel. Usually pan-reactivity suggests autoantibodies, But here the pan-reactivity was of varying grades. So since there is a prior sensitizing event, that is a history of recent transfusion, it can be either an autoantibody with an alloantibody or multiple alloantibody mimicking an autoantibody. So on analyzing the pattern in the strength of reaction, it can be multiple alloantibodies. And after combining the permutation and combination and also considering the dosage effect, the most probable combination can be small c and n, and other alloantibodies could not be ruled out. So it is only the most probable combination, which is small c and n. So in this case, there was a recent DAT positivity. In the antenatal period, the DAT was negative. And here there is varying strength of the reaction in the identification panel. And there is a history of recent transfusion 2 weeks back. And all these points towards a delayed hemolytic transfusion reaction. So this was a case of delayed hemolytic transfusion reaction masquerading as an autoimmune hemolytic anemia. And since the hemoglobin was 2.4 gram percentage, it was a transfusion emergency and we needed to provide units for transfusion at the earliest. And the most probable antibodies were small c and n, and other alloantibodies could not be ruled out. And multiple units was cross-matched, and around 23 units was cross-matched, which actually increased our turnover time. And out of the 23 units cross-matched, 7 units was found to be cross-match compatible. And on phenotyping these compatible units, only 5 units were found to be small c and n antigen negative. And this throws light to the importance of phenotyping in cross-match compatible units in presence of an alloantibody. So a cross-match compatible unit need not be antigen negative. So we got 5 antigen negative cross-match compatible PRC units, and the transfusion was given as 150 ml aliquots after leukoreduction under strict monitoring. And since it was a transfusion emergency and it was a precious unit, we cannot abort this transfusion at any cost, and leukoreduction was done as we cannot take any risk of FNHTR. And a total of 8 aliquots was given, and hemoglobin, LDH values and serum bilirubin values were monitored after each transfusion episode to look for any further hemolysis, and the intra-transfusion and post-transfusion period was uneventful. So here, as we can see, these are the LDH and the indirect bilirubin values after transfusion of each aliquots, and we transfused around 8 aliquots. And here we can see the hemoglobin values, and the hemoglobin value pre-transfusion was 2.4, which rose to 8.2 gram percentage after the 8 aliquots. And the patient was symptomatically better and was discharged on day 14. And the clinical response supported our conclusion regarding the specificity of the antibody. Now coming on to the case number 3. So this case was of a 38-year-old female, para-2 living to, with heavy menstrual bleed, who was referred from a local hospital in view of cross-match incompatibility, and there was no history of prior transfusion, and the hemoglobin was 6 gram percentage, and immunohematological workup was done, which revealed the blood group as ORH-D positive, and that was negative. O2 control was negative, and antibody screening and identification pattern corresponds to anti-small e, and the red cell phenotype was negative for e antigen. So this was a case of antibody against a high prevalence antigen, and no challenge was actually faced in identifying the antibody, and the real challenge was to find a cross-match compatible unit which was negative against the high prevalence antigen, that is anti-small e. So since it was a high prevalence antigen, multiple bags was needed to be cross-matched, and availability of such a large number of units to be cross-matched in our inventory was a real challenge. And we overcome this challenge by the interinstitutional cooperation. Actually, in our vicinity, we have 3 high volume tertiary care centers, that is our center, RCC and Sri Chitra. And as we cross-matched multiple units, samples were sent simultaneously to the other institutions and was cross-matched. And a total of around 75 units were cross-matched, and 1 AG cross-match compatible small e antigen negative unit was obtained and issued to the patient. So since a large number of units need to be cross-matched, it required large amount of sample, human resource and reagents. And since it was not a transfusion emergency, we had ample time. But if it would have been an emergency, the scenario would be different as there was an increased turnaround time. And the long-term management of such a case can be the establishment of a rare donor registry. And in our institution, we have started a project on the rare donor registry and have collected around 350 donors. And out of that 350 donors, 5 donors were found to be small e antigen negative. So now coming on to case number 4. So this is actually a very simple case requiring a technical troubleshoot. So this case was of a 1-day-old baby who was born to a Rhd negative mother, para-2 living to, who was admitted with hyperbilirubinemia in the exchange zone, and the sample was received for exchange transfusion in the baby. An immunohematological workup was done, and the blood group was ORHD negative, and the antibody screening and identification in the mother was revealed the presence of anti-D antibody, and the baby blood group was ORHD positive, and that was positive in the baby. So in case of exchange transfusion, we need to be cross-matched only with the mother sample and not with the baby sample. But here the blood bank technician cross-matched with both mother sample and the baby sample, and the donor bag was found to be compatible with the mother sample and incompatible with the baby sample. So the most possible cause can be the contamination of the reaction chamber with the baby's DAT positive cells. So actually I have included this case as it is a scenario which we often encounter in the blood center, and the importance of adequate centrifugation. And this simple troubleshoot will resolve the problem. So we double centrifuge the baby sample and cross-match with the supernatant, ensuring that no DAT positive baby cell entered the reaction chamber, and it was found to be compatible. Next, moving on to case number 5. So this case was of a 1-day-old baby born to a Rhd negative mother who was admitted in IBN with hyperbilirubinemia on the exchange zone, and we received sample for exchange transfusion. So we did the blood group of the mother, which was found to be BRHD negative, and to our surprise, the B blood group was also BRHD negative. And then we did the DAT on the baby sample, which was positive, and antibody screening and identification was done on the mother sample, which revealed anti-D antibody. And since the baby was DAT positive, weak D testing was not reliable, and we came to a conclusion that it can be blocked D phenomenon. But we didn't proceed with elution to confirm the identity to the elevate, as the baby was in exchange zone and hemodynamically unstable. So we asked to repeat the baby's blood group after 4 months. Then moving on to our last case. So this case was of a 1-day-old baby who was referred from the peripheral center with hyperbilirubinemia in the exchange zone, and the hemoglobin was 8.8 gram percentage, and the peripheral smear showed the evidence of hemolysis. And we received the request and sample for double volume exchange transfusion for the baby. And at that time, the mother was in the peripheral center, so only baby sample was available, and we requested for the mother sample and proceeded with the baby sample. And the blood group of the baby sample was BRHD positive, and that was positive in the baby sample. So as mother sample was not available, we were forced to cross-match with multiple O negative PRC units, and we cross-matched with multiple O negative PRC units, and all was found to be incompatible. By then, we received the mother sample, and the blood group was found to be BRHD positive, and the antibody screening and identification revealed the presence of anti-small c antibody. So we cross-matched with BRHD positive unit, and cross-match compatible unit was obtained immediately, and cross-match compatible small c antigen negative unit was issued to the baby for exchange transfusion. So this case shows the importance of maternal sample, and the specificity of the antibody decides the Rhd phenotype of units which need to be selected for cross-match, and antenatal first trimester screening enables timely detection of the alloantibodies and the treatment of HDFN. And we can also save time needed for the identification of antibodies. So these were some of the scenarios which we often encounter as cross-match incompatibilities, and each case is unique, and the management should be individualized by assessing the patient condition and analyzing the risk-benefit ratio. So in case of cross-match incompatibility, we should assess the situation and look for the urgency of transfusion, and we should decide on the level of workup possible within the available time. And we have seen a case of delayed hemolytic transfusion reaction, which was presenting as a typical autoimmune hemolytic anemia. And we have seen the importance of identifying the specificity of alloantibody in determining which units need to be cross-matched. And cross-match compatibility cannot be relied upon completely in case of alloantibody. Phenotyping should be done. And we should identify the most probable specificities in case of multiple alloantibodies, and we should monitor each transfusion episodes with the laboratory evidence of hemolysis. So last but not the least, it is important to identify the local resources and referral facilities, and interinstitutional cooperation is needed for timely provision of transfusion support. So that's all. Thank you all for listening. I also thank TMS for providing me an opportunity to present my case. Thank you.
Okay, thank you, Adya. Compilation of so many cases. Regarding case number 3, that
Sir,
small
not audible.
is it?
Hello.
Hello.
Yes, sir.
Yes, sir. Go ahead.
So, but you said that 7 is compatible, but only 5 are negative. So, I could not take out from the presentation that when you boiled down to small c and n, did you feel?
Sir, not clear, sir.
I'm not clear. Hello.
Hello.
Yeah, now better.
Hello. Adya, can you?
Hello.
Hello.
Yes, sir.
Adya, are you there?
Yes, sir.
So my question was, like, remember in the 7 are compatible, whereas only 5 are C and they're negative.
It's not audible, sir. I can't hear you.
Sir, the audio is breaking.
Am I audible now? Am I audible now?
Yes, sir.
Yeah. So what I was asking is, in your third case, I suppose you said out of the 7 which were compatible, only 5 were C and N negative.
Yes, sir.
So what is your explanation for that? Like, had you confirmed the antigen negativity of that patient for C and N already?
No, sir. Actually, we cross-matched with multiple units, and the cross-match compatible units were phenotype for the small e
Yes,
antigen.
that's correct. Did you phenotype patient for C and N before declaring the possible antibodies are C and N?
Sir. Sir, in case number 3, right?
Yeah.
Yeah, in case
Small
number
C
3,
and N.
the patient was phenotyped and was negative for small e antigen.
Small c.
Small e.
Small c and capital N, right?
Sir, case 2, sir.
I think case 2, I'm not sure. C and capital N is what you showed.
So that was case number 2, sir.
Okay.
Actually, we didn't phenotype the patient as there was a recent history of transfusion in the patient.
Okay, fine. Okay. So you have any explanation why those two were compatible but were not C and N, still C and N positive?
Sir, due to the dosage effect, sir. We got 7 cross-match compatible units after cross-matching about 23 units, and those 7 cross-match compatible units were phenotyped, and we got only 5 cross-match compatible units, which was small c and N antigen negative. And it
So
can
your
be due to the
equation for the
dosage.
other two is dosage. Okay, fine. Okay. Anything from others? Any doubts? Anything? I don't see anything on the chats as well. Okay, somebody has asked, can you tell something on rare donor registry?
So in our institution, we have started a rare donor registry, and we have collected about 350 donors, and their phenotype for capital C, capital E, small k, Duffy A, Duffy B, JK, JKB, LEA, LEB, M, N, and capital S. And we need a total of 1,500 donors, and now we have reached around 350 donors, and they are being phenotyped now. And the process is ongoing, sir.
Okay, so that's a nice initiative. So you are doing it from the institute or some funding?
It is by the Kazakhs funding, sir.
And are you including all blood groups or only O?
No, we include O group only, O positive and O negative.
Only. Okay.
What are the criteria for selecting donors for donor registry?
Okay. We include the donors, O group donors who have donated more than 5 times and who are residents of Kerala and who are willing to donate and come to donate at anywhere in Kerala, and they are willing to stay for the next 10 years in Kerala. They are settled in Kerala. Actually, we take those donors for phenotyping. And the age was usually we select less than 40 years of age.
Excuse me, sir. Can I ask you a doubt, sir?
Yeah, please go ahead.
So what could be the critical factors which are taken into account while establishing the rare donor registry, especially in India? Like what are the factors we have to take into account?
So, like she said, actually, yeah, they are targeting Kerala. So about the Indian rare donor registry, it's also similar. Like first thing is to make sure we don't have a strict guideline like they should have donated at least 5 times, but we look at the commitment definitely, and we have not restricted for the I mean law for their residence anywhere, because the idea is to ship the blood if required from anywhere by donating at the nearest blood bank available. And yeah, we also age cutoff is little higher. We go up to 50. That is one thing. And only additional thing that we are doing is we also are doing genotyping. Because the intention is to prepare panel cells as well. Otherwise, whatever Hadia said almost looks fine, including O donors. But I'm not very, I mean, though we have started with O donors, but I'm not very particular. I mean, if somebody asks me, I'm not very particular that should be only O, because we should also be aware that for example, in our area, B is almost as common as O. So even if we include B, like most of the time, it's possible that the patient who requires a rare blood is also B. So it's that is one more thing that we are looking at. Otherwise, there is nothing. Like, of course, he should fit to the regular donor criteria. And commitment is important, because especially in these kind of things, when you invest so much on phenotyping and all that, and the donors are lost from the pool, that may be slightly disheartening. So of course, with whatever precautions you take, some people will miss out, but that's more important, the commitment of the donor and other things.
Okay, sir. Okay, thanks.
Actually, we have some fund constraints and we are now in the initial phase. That is why we are considering only O blood group donors.
Yeah, definitely, no problem.
Any more queries or suggestions? So I would like to thank Abhishek sir and also the participants who have come forward to talk about their interesting cases. And next week, like in May 4th, we are having a session by Dr. Sudipto Shekhar Das on evaluation and management of IHA case-based approach. So hope we can see you all then. Thank you.
Thank you, one and all.
Thank you.